Well, it is a great pleasure to be here again. It's nearly a year since I was here last to operate, and that, in fact, was the last operation I performed in Europe for congenital heart disease. I was asked to give a keynote talk to our own society, and they gave me the title of Decision-Making, When to Operate and When Not to Operate. And I thought, yeah, that's a nice title. So I accepted. And then I thought about it a few minutes later and realized that that was actually a very, very difficult subject indeed. And I was given the talk because it's 40 years since I graduated, and I suppose they thought after 40 years I might have learned something that I can pass on. Well, I've learned a lot of things, but I'm not sure I've yet learned exactly when to operate and when not to operate. But in part, the subject that I was given was the past, present, and future. And I talked about that last year, and I thought, well, maybe some of you would have been in the audience last year, and you don't want to hear the same thing over again. So it is actually a combination of both. So as I say, I graduated in 1979. And back then, the Society of Cardiothoracic Surgeons in the UK did have a fairly crude database. And I won't linger on this too long, but there were 44 units. There were 2,000 open heart operations in children, but look, there was a 12% mortality overall. Closed operations even then had a 7% mortality, but they didn't split them at that stage anymore. But when we looked at something like coarctation of the aorta, which will generally be done in the neonatal and infant period under 1, we're looking at a mortality of 17, nearly 18%, 40 years ago. Now, when it came to the actual breakdown of it, those that were less than 1 year old who underwent open heart surgery, that is surgery on cardiopulmonary bypass. So if we look at a VSD, there were very few under ones, but even those who were over 1, well, the mortality was only 3.4%. But if we look at those less than 1 year old, we have a very high mortality, 18%. When we look at transposition of the great arteries in the era of the atrial corrections, Mustard and Senning, we're looking at a risk when it's associated with a ventricular septal defect of at least 26% or 40% if they're beyond 1 year old. And as for truncus, very few were operated, and of those, very few survived. So the overall mortality of the 370 children less than a year old who underwent surgery on cardiopulmonary bypass was 17%. 1 in 6 were dying. Now, if we move forward, the results have been analyzed. And if we look at the trend from 1977 over a 20-year period, you can see firstly that the number of congenital operations has risen slightly from 3,300 to 3,800 or near 4,000, but the mortality has dropped to 4.1% by the mid-90s. And this trend had also improved when we looked at those less than 1 year old, down to 7.5%. So there was clearly a considerable improvement. But nevertheless, some of you who perhaps have worked in the UK will be aware of the so-called Bristol scandal. And this resulted in a major change in government attitude, and particularly the Department of Health, towards what was happening to public money that went to these cardiac units. The government and the general public wanted to see value for money and good outcomes. And so a major inquiry resulted in major changes. And today we're very carefully and closely analyzed, and here are the results of isolated coarctation surgery, the vast majority under 1 year, and mortality is rare. The overall mortality is about 1 to 2%. When we look at something like a VSD closure, we're also looking at a mortality in the range of 1%. Tetralogy of Fallot, similar results. And the arterial switch operation, with or without a ventricular septal defect, also has a mortality in the low single figures. So, past, present, future. Well, I don't know who it was who said it, but the more extensive a man's or woman's knowledge of what has been done, the greater will be the power of knowing what to do. And I don't think many people would dispute that. And a quote from a very notable pediatric neurosurgeon who passed away in 2009, and his obituary quoted him as saying, "It takes 10 years to learn how to operate. Another 10 years when to operate, and the rest of your life when not to operate." And I can testify that that is a reflection of my own career, and many senior surgeons feel the same. Now, here I am in a land that is famous for its philosophers, and I'm going to be a little bit philosophical, which is perhaps a dangerous thing to do in this environment. But Aristotle observed that the heart alone of all viscera cannot withstand injury. And many of those ancient philosophers were also physicians, treating soldiers, treating gladiators, and so on. And they noticed the various injuries that they dealt with, and he made the observation that an injury to the heart was serious. Evidence-based medicine, if you like, in the very early. Now, Galen, I came to realize, was also Greek, but went to Rome to look after the emperors, presumably because they couldn't find any decent Roman doctors. And his thinking prevailed for really 1,500 years or more. And he analyzed disease in terms of the four humors of black bile, yellow bile, blood, and phlegm, which we all know are completely erroneous. But that dominated medical thinking for 1,500 years. And he observed that the best physician is also a philosopher. His theory of the circulation was an open-ended vascular system, but air and blood in the arteries, and that there were pores within the heart that allowed venous blood, he thought, was made in the liver, and then passed through the ventricular septum through mysterious pores, which he never was able to demonstrate, to get to the other side. And that was the thinking of the circulation. But William Harvey, an English physician trained in Padua, was the man, of course, who discovered the true nature of the circulation. And he risked his reputation to break what was established and thought to be the true beliefs of Galen. It was a risk to step outside what was accepted. But it was soon realized that William Harvey was right. So over the next 400 or 500 years, was there major progress? Well, I won't go into it, but it was thought up until the end of the 19th century that an operation on the heart was impossible. And even so, Sir Thomas Lewis, who observed the electrical activity of the heart, those very small voltages could be measured and captured, and invented what we now know as the ECG. He was a very serious-looking man, but when he had a glass of beer, he looked a little less so. But he published a book in 1945, and in observing mitral stenosis, although many symptoms may be complained of by patients suffering from mitral stenosis, there are none that can be ascribed properly and usefully to this deformation of the valve, and went on to say that it's got nothing to do with the mitral valve. Well, as they say, timing is everything. Unfortunately, the surgeons of the era were practical men and realized that an obstructed valve couldn't be good for you. And 2 years following, Dwight Harkin performed the closed mitral valvotomy. And in 1956, the operation was so successful that he was able to publish a series of 1,000 and brought in the era of cardiac surgery. So when to operate? Well, there's a saying, and Warren Buffett is attributed, never ask a barber if you need a haircut. And someone else said, never ask a surgeon if you need an operation. But barbers are ingenious and will find ways of dealing with various parts of a man's anatomy or woman. And I won't go any further at this time of day with the audience. Now, these are other quotes. Heracles of Ephesus observed that doctors cut, burn, and torture the sick, and then demand of them an undeserved fee for such services. I hope things have changed. And David Lloyd George, a very notable politician at the beginning of the 20th century, Prime Minister of Britain, doctors are always changing their opinions. They always have some new fad. Now, that's actually quite true, and I've seen a few come and go over my career. Make a habit of two things, to help or at least to do no harm, from Hippocrates. So when to operate? Well, in this era, we try to base our decisions on what are called evidence-based medicine. And there's this pyramid of how to build up evidence. But it comes down to a combination of clinical judgment with relevant scientific evidence and, of course, taking into account the patient's values and preferences. There's this triad. Other people have looked at it. Best external evidence, patient's value. It's all the same thing, really. But individual clinical expertise is very important, and that's why I like the diagram on the right. Furthermore, you then have the factor of the health system that you're working within. The availability of drugs, the availability of the finances, because I don't know any country on earth that has unlimited finances to fund all that we are capable of doing or that our patients expect of us. Now, a colleague of mine, John Simpson, who's a very notable echocardiographer, made the observation, there's no such thing as the journal of bad results. And that is true because there is publication bias by authors and editors, so that the evidence that we take from the journals is biased towards when there's good outcomes. And over my career, I've seen situations where you're sitting in the weekly MDT and an unusual case is presented and a senior staff may say, you know what, we've seen quite a lot of these recently, and turns to one of the residents and says, why don't you go and look up over the last 20 years and see what goes on? So off they go and they come back a month or so later and say, yeah, you know, we've had 95 of those cases and 94 are alive after 20 years. Really? We've got to write that up. On the other hand, they may come back and say, we've done 95 and there's only 5 alive and most of them are in a very poor state. Really? Oh, gee, that's a bit of a shame. And so we've all, so evidence is selective. Evidence-based medicine in the context of surgery is to apply the evidence in order to operate, but crucial to that is to audit and observe the results of the surgery that you have carried out or the treatment, whatever it is. Now, in all biological systems, there is the bell curve. The bell curve of our patients. And the distribution is the same. And in a mass population, there will be a distribution of those that fall within the norm. At the other end, there's the extreme, either those who are extremely tall, extremely overweight, extremely thin, whatever. But there are also the bell curve will apply in context of treatment. The majority of patients will respond in a standard way to a certain treatment, be it an operation or a drug. But there will be those who have an extremely good response, and there are those that have an extremely poor response. We cannot tell at the outset. But throw in another factor. Surgeons are human beings. There is a bell curve of surgical ability. It's a shocking statistic to know that half of the surgeons in the world are of below average ability. So there are those who are poor performers. The majority, hopefully, are average performers. And some are high performers. And these two factors will feed into decision making. And it is very important for a surgeon or a doctor to be aware of where they are on that bell curve of performance. Most people have insight, but some lack it and take on treatments and operations that are not within their ability. Now, I've mentioned the bell curve. Many of you will recognize this individual, Cristiano Ronaldo, who is notable, and David Beckham. I hasten to show him because I think he scored a free kick that put Greece out of the World Cup qualifying a few years ago. But nevertheless, the physics of what they do, which is to bend a ball over and round a defensive wall, is just physics. They make the ball spin so that the air on one side causes more drag than the air on the other side, and so it curves and goes into the goal. So there it is, it's the physics. Surely we can all do it. The same is true when Rory McIlroy strikes a golf ball. He will impart spin on it so that it goes in one direction or another direction. It's just physics. Surely we can repeat it. Well, we know most of us, in fact, all of us cannot, because we do not have that superior skill. I'm sure it's true in Greece, but much is made in the UK of the comparisons that exist with the aviation industry, which of course has to be very, very safe. And in fact, as we know, statistically is the safest form of travel in terms of miles per mortality. Now, planes operate with the thrust, the weight that wants to take it back to the air, to the ground, a drag, and then the lift that's imparted from the wings. And the aerofoil principle is very simple and obeys the laws of physics. So aeroplanes will fly by the laws of physics, and as long as they're moving forward and the air is passing over it, that plane will not fall out of the sky. The bell curve element doesn't apply to physics. It applies to biological systems, and the only biological factor in the airline industry are the human beings, the pilots and cabin staff, but particularly the pilots. Medicine and surgery, unfortunately, are subject to the laws of biological science. So the bell curve of performance applies both to the patient response and to the operator. So when to operate? Well, of course, prognosis may be a reason. The condition itself is life-threatening, either immediately, and in the context of congenital heart disease, duct-dependent circulations, an aortic dissection, severe septic endocarditis, or over time, the condition may have a greater risk than the operation, and that the operation can improve the long-term survival, as you would expect in aortic stenosis, Marfan's, Fallot's tetralogy, etc. The operation should carry less risk immediately, or it protects life in the longer term. An ASD is not going to kill you today, this week, next week, probably next year, but left untreated in a young person will shorten life overall, so that the operation is justified on that basis. But the patient is generally not ill. Symptoms. The patient may be experiencing symptoms that the operation may relieve them of, or it may prevent the development of symptoms and a deterioration. And then there are lifestyle, and certain employments may require it, recreational, and of course a PFE in the context of deep sea diving and such like. Now, there are difficult decisions, and I'm not going to, but asymptomatic disease, valvular regurgitation, be it the aortic or mitral, indeed pulmonary, valvular stenosis and atrial septal defects. The onset of symptoms may indicate that the heart is failing, decompensating, and we don't really want to allow that to happen. But the operation is always easier to justify when the patient is sick. The family can see that father or brother or whatever is not well, and everybody can understand why an operation is needed. But we don't want to leave it too long. And what we're trying to do is avoid a situation where the risks have increased or the prognostic benefit may have been reduced. So with reference to valvular regurgitation, I quote Michael Tynan, who was professor of cardiology at Guy's when I was appointed. And he said there are only two times we operate, which is either too early or too late. But I've said to many patients, if I make a mistake, I'd rather be too early. Tynan, incidentally, is now 85 years old and continuing to enjoy good health. And I saw him only a month ago over a glass of fine wine with my namesake, Bob Anderson. So the indicators of timing in the context of valvular regurgitation will be things like ventricular dimensions, echo or through MRI, pulmonary pressures. CPET has emerged as a very good way of monitoring the decline before it becomes symptomatically obvious. The repairability of valves today is encouraged in intervention when perhaps the only option we had years ago was mechanical replacement. There are, of course, issues of pregnancy which may influence the decision making. And of course, somatic growth may influence the decision to hold on if we cannot repair a valve. Now, in the UK, there's a great enthusiasm for protocols and guidelines. And a guideline defined as a document with the aim of guiding decisions and criteria regarding diagnosis, management, and treatment in specific areas of healthcare. But a protocol derived from the Greek words, I believe, protos first, and a glued page, I'm not going to go any further on that. A written plan specifying the procedures to be followed in giving a particular examination, conducting research, or providing care for a particular condition. So much more rigid. Now, many of your modern cars have got satellite navigation systems. And I don't know about the Greek versions, but I know that the versions we have in the United Kingdom can lead you astray. And protocols can do exactly the same. Rigidly applied, they will behave like satellite navigation systems. If you slavishly follow them, you'll find yourself in trouble. Like this. These are true. This truck on the right apparently has Irish registration plates, but it cannot be driven by an Irishman because they wouldn't do something as stupid as that. So this sign went up in a small village somewhere in England. Sat nav is wrong, use your brain, get out of here. So when it comes to evidence-based medicine, we need to use evidence with a healthy degree of skepticism, recognizing that there's no such thing as the journal of bad results. And when you come across something unexpected, be ready to alter your course, just the same as if the satellite navigation system in your car tells you to turn left and you can see that by turning left you're going to drive into the river. Think of the future and try to avoid repeat interventions. Patients want, well, they don't want any operations, but what they want is one operation and that's it forever. Now, often we cannot, but we can devise treatment strategies which minimize the frequency of future operations. Use basic, simple concepts to guide you, flow and resistance and diameters. And I say this with some caution. Don't let the intensive care doctors dictate your management. You're a qualified doctor as an operating surgeon. You should be able to understand the circulation. You're not just a plumber. And don't be afraid to recommendation that may not be the right may not be the right option. On the basis of evidence-based, sometimes you get situations where you've been told you've got to do this operation, you say no because. So say, and of course at all times retain the humility and empathy and compassion, especially with the patient and family and towards your colleagues. But there are perverse incentives. The gentleman on the right is a famous actor who played a surgeon known as Sir Lancelot Spratt in comedy films of the 50s and early 60s. So this is an old joke that goes around. What did you operate on Smith for? A guinea was the way in which doctors charged their fees in times past, and it's the way that racehorses are sold today. 100 guineas. No, I mean, what did he have? 100 guineas. Don't tell me it doesn't happen. Doctors are human and they're frail as well. When we quote a risk, doctors, some surgeons can be unrealistically optimistic. So I must warn you that this operation carries a 99% mortality risk in my hands. Then why are you going to operate on me? You'll be my 100th patient. So, when not to operate or to step back and consider hard. When the natural history and risk of is the same as that of the operation. When all we can do is to stop death, but we cannot make the patient live again. That's an ever-increasing feature of modern medical practice. Some people say it's just prolonging death rather than actually. I think we all graduated from medical school or went into healthcare with the object of returning people to life and health. Of course, we've got to stop them dying first before we can do that, but sometimes that's as far as it goes, and I'm not sure that's a very good objective. In the context of complex congenital heart disease, we need to be mindful that neurodevelopmental damage will have a massive impact on the patient and the wider family. Major chromosomal abnormalities may dictate prognosis way beyond what the congenital heart defect, and we would rarely, if ever, operate on trisomy 18 or trisomy 13 in the UK. Trisomy 21, there's no problem. That is actively treated in all circumstances. And of course, when the operation is beyond our personal or our unit skill set, we should have the courage to say, I think this patient should be transferred to another center. Saving face should never be secondary to the patient's life and a good outcome. And of course, if the patient does not want an operation, we should be careful not to persuade them against it. So back to the 5 steps. We operate and then we audit. And I'm pleased to see that there is now a more active audit and data collection system going on here. And finally, Hippocrates. Of the epidemics, he's quoted, the physician must be able to tell the antecedents. That refers to the past, what's gone before. To know the present, that comes through education and training. And to foretell the future, which refers, of course, to prognosis. He must therefore mediate these things and have 2 special objectives in view with regard to disease, namely, to do good or to do no harm, now known as evidence-based medicine. But without the data, we risk continuing harm and not doing good. And finally, Sir William Osler, the good physician treats the disease. The great physician treats the patient who has the disease. And there I must end. It's been a great pleasure to have been involved in the work here at ΜΗΤΕΡΑ, and I congratulate all the staff on what has been achieved over the last 6 years, and I'm very proud to have played a part in it. Thank you all.